Me van a ver con la geoscopio de 9 French. Hello. Hello everybody. So welcome back. We have a nice case today. No, quiero contraste. We have a nice case today. This patient is a 77 years old woman that was had a surgery, a gallbladder surgery 30 years ago, but she had a complication and they do it biliodigestive anastomosis at that moment. So now it's coming to our center because of jaundice and because of the surgical team doesn't want to make a new surgery. And you can see here the common bile duct completely divorced, and you can see the anastomosis there. So necesito la imagen con la endoscopia grande. Eso. So you can see very well. And now I will try to get an access directly. Quiero la guía. So I will pass my guide wire now. And I will make a fistula to go inside the biliary tract to try to see what's happening, and if I have any chance to see if where is the anastomosis, and if we can reach the stenosis, and then trying to so now I am fine. I will remove my needle and espacio. So it's very important to never lose your access. Okay, so I see my guide wire on US very well. I see my guide wire is very well placed, and now I need to make a fistula. I will use one cystosome, 6 French cystosome, to go inside and perform the direct access to the biliary tract. So this is an hybrid technique that I call it US guided cholangioscopy. So what I want now is to see what is going on inside, because it's very important to see. This is completely different. It's not the same to see by X-ray, just by contrast, and doesn't understand what is going on. This patient didn't have jaundice, so I need to see what's happening. So now I will use the endocut eye effect 2 to do it my access with the cystosome. Very important to see if there is any vessel here. I don't see any vessel, so I'm fine, I'm sure. So now I need to cut, try to avoid that vessel. So now I am inside. You can see there, you can see here, I'm inside, and that is very good. I will try to see if I can reach the stenosis. So it's better to see by cholangioscopy. Okay, so now I'm good. Empuja. Yes. So now I have the access. Puedes poner las dos pantallas en grande. Ahora necesito un balón de dilatación. ¿Puedes poner las dos pantallas en grande? Ah, perfecto. So this is very good. This is very important because you need to see your axis is here. You can see here very well. Sorry. Here's my axis. Here's my biliary tract by US, and I see very well my axis by cholangioscopy. So now I will use a balloon dilation. I'm using a hurricane. Un hurricane? ¿Qué es? Yes, I'm using one hurricane, 6 millimeter by 4 centimeters. Ten aquí. So because I need to do the fistula now, and in our experience, going inside directly with the cholangioscope is not a big problem. So we can do it. We don't need to wait for the fistula, just in certain cases. So we have a big series now, and I'm trying to make the publication now about this technique. So you can see here I'm inside. Okay, so now I want to make a balloon dilation. Dilata todo. Okay, so here, this is very important. You need to see here by US the dilation. This is the dilation of the wall. This is the dilation of the liver. ¿Está todo? Okay, desinfla. So now I want to make a dilation more inside. Ten. Aspira. Okay. So now I need ahora dilata. So I will make a second dilation. Everything is do it. Okay. Desinfla. Ahora dilata de nuevo. I will make a new dilation, and that will be fine. That will be okay. So you see here, the vessel is here, the artery is here. I'm here. I'm not touching the vessel. You see, you need to be very precise in these cases. So now I am fine. Desinfla, and now I will. Una más, una dilatación más ahí. Okay, perfect. Okay, desinfla. So now I will remove my balloon and I will pass my cholangioscope. It's a small leak. It's okay. Don't worry about that. Because at the end we will less one stent. So the leakage will stop. Always antibiotic before this, because all the risks that we have. So I will pass a 9 French cholangioscope. This is an IMAX. I want to have good maneuverability first, and the other advantage of the IMAX is that the tip of the IMAX, the tip is round, so it helps in an easier way to go inside the biliary tract. So now I'm trying to move forward. Necesito ver lo del IMAX acá. ¿Cómo hago la imagen acá? 10. Momento. So this part is very critical. It's very important to see where's my axis, my biliary tract. Is very important. So okay, now I'm looking. Está mi guía. ¿Qué se te viene la guía? Empuja la guía. So I'm trying to see where is my guide wire. Is okay. It's very important to see the guide wire. The guide wire is here. Cierra aquí. No tanto. It's very important here. Ten ahí. I need to make a balloon dilation, a better balloon dilation, because I'm not fine. I'm not perfect to go inside. Ok, ten aquí. Solo ten ahí. Solo las cuerdas tenlas. This is critical. Ten ahí. No. Ok, necesitamos dilatar un poquito más. Empuja la guía. Ten ahí. Ten ahí, espérate un segundo. No. No. Maybe. Ten ahí. No, tengo que dilatar. Okay, I will make a balloon dilation, another dilation, but with a big balloon. Seis, siete, ocho. I need to make a dilation, a big dilation, better dilation. Momento. So now I am using a 678 balloon to make a better fistula. Okay, so now, okay, dilatemos. 6. Todo. Okay. So you can see here the balloon. So the dilation is much better. Trying to... Okay, desinflamos. Okay, dilata ahí. Ok, desinflo. Empuja la guía. So now we are inside the biliary tract, you see? Perfect. So we need to dilate a little bit more, but it's okay. So now I am inside the biliary tract. This is what I believe is the next generation of the treatment of biliary tract is endosurgery, guided by cholangioscopy. Imagine that we can do a lot of things with this. So now I need to see if I can find out where is the anastomosis. It's not completed close. This is very important. Let me see where I am. Now I am doing a I need to find out if there is a complete stenosis or not. It appears to be a complete stenosis. Maybe it's here, huh? You can see here really a small hole that is very difficult to manage just by, you know, just by just by fluoroscopy. You will make a lot of radiation. Wait, momento. Maybe I'm right. I'm not so sure, huh? I pass here. I'm not so sure. So what I will do now is to put here. I need to pass. Empuja la guía. Okay, no importa. So, empuja. So I need to see if this is anastomosis, huh? I need to pass the sphincterosome now to see if there's the small bowel or not. But this is the anastomosis for sure. So I need to see very well. I need to pass contrast. Rayos X en grande. Rayos X en grande. No, 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 no. No quiero eso. Ten. Momento. Mete contraste. Ok, déjame ver. So that is a small bowel, huh? Empuja. Sí, empuja, empuja, empuja. Okay, so that is a small bowel, and that was the side exactly that I needed to pass. So I will try to pass with this. It's a little bit difficult, tricky. Now I'm inside. Now I'm inside. Very good. Just confirmation, this is a small bowel, you see? Very good. So now I need to make a dilation. Empuja. I will confirm el balón de vía biliar. Hurricane. So I will use the hurricane balloon again. I will make a small dilation. So this is I believe this is the next generation for surgical endoscopy of the biliary tract. This is the way that we need to use it. You see, it was impossible to use it just by fluoroscopy. It's not the same to see inside and to make the treatment inside. ¿Qué piensa Daniela? Are you with me or not? Daniela say that. Daniela Tabachella from Romania, she say that it's okay. So if she say that it's okay and Raquel say that it's okay, so I'm okay. Now, I will make a small balloon dilation. I will pass my cholangioscope just to confirm that I'm, I am inside the and then we will make the whole treatment. So now the idea is to confirm, to pass my cholangioscope, to record this, and then to make the treatment for this patient. So the surgeons from my unit, my colleagues here, they know that it's 10. Ahora sí pasamos. Okay. Ahora sí, dilata. Okay, desinfla. Ahí, infla. So you can see very well. So now we will stay here few moments. ¿Estás ahí? Yo no dije que desinfles. Quiero que tengas ahí dilatado. Ok, son desinfla. Ahí infla. Y tenlo ahí 1 minuto, 2 minutos. Infla. Okay, so perfect. We are perfect now. Very nice. So I will rest here 1 minute, at least, and then we will move with my cholangoscope to see. Okay, desinfla. So now we are okay. So now I need my cholangoscope. I will pass through just to see the small bowel, confirm, and then I will pass a big balloon. Necesito uno de 8, 9, 10, and I will make a balloon dilation up till 10 millimeters to make a calibration. If there is any leak, it is not a big problem because we will less one plastic stent for a moment, and we will retake the patient in 2 months, 8 weeks, to see how is the anastomosis. And once it gets, it is clear. So I will finish in 2 months. But if not, I will put a metallic biodegradable stent. Momento. So now we are here. Let me see where we are. Well, so this is a small bowel. You can see here, right? So we confirm that we are in the small bowel. Perfect. So I'm fine now. Finally, you saw that it was a small hole. I didn't have too much chance, and now it's perfect. Now it's perfect. Okay. So okay, empujan la guía. So this is something that could happen. This is stenosis of the anastomosis. You can see here. 30 years after, huh? But we are avoiding new surgery, so we are doing a endosurgery from inside. And this is one of the big advantages of this technique. Sí, quiero un balón de 8, 9, 10. So now I will make a dilation until 10 millimeters, and I will less a plastic stent, double pigtail, and finish. So give me 5 minutes more. So this avoid a new surgery, and normally this surgery is very nightmare for the surgeons, because after the surgery the patients go to the to the intensive care unit, risk of fistula and risk of new stenosis, 30% to new stenosis after the surgery. So in this way we don't need to send the patient to intensive care unit. This patient just needs ambulatory or hospitalization just 1 day for observation, and if everything is fine, you send the patient immediately here in the unit. So this patient don't need to stay too much here. She will stay just 1 day and finish. Dilata. Todo. Hasta 10. So now I'm making the dilation. You see there the stenosis. So now we are until 10. Perfect. Okay. Okay, desinfla. And one of the big advantage over radiologists is that we don't less a catheter outside. So everything is inside and the patients make his normal life. Perfect. Empuja la guía. Empuja, 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 empuja. Aspira el balón porque no sale. Ahora sí, ya. So now I need 7 French by 10 centimeters. Double pigtail. And we will finish. And we will send this patient. We will see the patient's 3 hours here. And we will send home. Imagen endoscópica en pequeño, ¿ah? Dile que la imagen endoscópica en pequeño, por favor. Oh. So quiero ver bien, ¿ah? Ok. Ahora sí bajar. Ajá. Vamos un segundo. Quiero ver acá. Ok, listo. Ok, comienza a liberar. Momento. No. Empuja la guía. Ok. Libera. Momento, despacio. Okay. Okay, libera. So now you can see here very well. So the stent is passing the stenosis and inside the lumen, inside the gastric lumen. So it's perfect now. So it will continue draining both sides, so not just in the stomach, also in the anastomosis, in the small bowel. Okay, so I finish. I show it a little bit how to do it. I think was very nice case. The stent is very well placed. And on a photo, okay, picture. And I will retake these patients in 2 months. Thank you so much for your attention. So I invite you that in a few weeks we will make a live transmission for São Paulo University. So Gastron, I'm very glad to participate with you, and also invite you in August to our live congress online. Will be held from Ecuador to the worldwide. So 87 countries and more than 7,500 physicians connected together to learn about new technologies and technique. Thank you so much and see you soon.